I only have time until 10:55, so just 15 minutes. So maybe we start, and your colleague will join us a little bit later. So what I said yesterday was, maybe I share the screen now. Oh, wait. So we talked yesterday about the vascularization of the small bowel and the colon. And what I mentioned, I want to briefly repeat the relevant structures here. So I talked about the celiac trunk. I talked about the superior mesenteric artery, the inferior mesenteric artery, which are just positioned in the midline of the abdominal aorta. Then additionally you find here the medial sacral artery, and these three arteries, the celiac trunk at T12, the superior mesenteric artery and the inferior mesenteric artery, they're responsible for mostly for the innervation of for the blood supply of the abdomen. So you should always keep that in mind when we talk about these structures, that these are relevant structures for all internal organs. Talking about the celiac trunk means talking about three relevant vessels, and this is the left gastric artery, the splenic artery, and the common hepatic artery. So three arteries which are relevant, relevant here. And from the left gastric arteries, you have just the lesser curvature of the stomach, which is connected then with, or has an anastomosis with the right gastric artery, and the right gastric artery comes directly from the common hepatic artery. You see that here, this is the right gastric artery. So some more words about the common hepatic artery. You see here, this is the proper hepatic artery, where you see here in the division of the left and the right gastric artery, and then you find in the midline the cystic artery. So do you have so far questions to that? I think it came in a little bit broken, so let me switch off my webcam. Okay, so the next one is a question. So this is for all the abdominal supraepigastric structures you find or supplied by the celiac trunk. The rest comes from the superior mesenteric artery, which is just here, next to the duodenum. And this is something we see here on the next slide. So this is high power again. You see this is the left, the splenic and the common hepatic artery with the right gastric artery. This is the proper hepatic artery, the left one and the right one. I also mentioned that there are some variations in there. So mostly you find the supply of the liver arteries by the division of the common hepatic artery and then the proper hepatic artery. But it could happen that you have the left liver artery comes directly from the left gastric artery, or it comes from the superior mesenteric artery. So this is nothing which is written in stone. It's not something which is a rule. So there are some variations that are in there. Then we talked about the superior mesenteric artery. You see this is a kind of loop, and this loop is built up by the anterior and posterior superior pancreatic or duodenal artery, which supplies, or this network of loops supplies the head of the pancreas. So for the superior mesenteric artery, we see this is one of the first branches is this inferior pancreatic duodenal artery, which goes directly then to the pancreas head, and the other ones, so the the upcoming arteries, which arise from the superior mesenteric artery, they are now responsible for the supply of the small bowel, but also for the right colon. So some works for the blood supply of the pancreas. You see that here more detailedly. You find the portal vein is just on the back side of the pancreas. You see that. So there is also, by the way, if you have a tumor, pancreas head carcinoma, it could happen that you have also an infiltration of the portal vein. So the portal vein is just encircled then by the superior mesenteric artery, and you see this is the inferior pancreatic adrenal artery, which is building up this loop, and just above the pancreas itself you find the celiac trunk. So this is really in a close relationship. We talk about maybe 4 to 5 centimeters. So this is really nothing in terms of dimensions. It's very close, and it could happen that you for sure have some irritations there. Some words to the lymphatic on the lymph nodes around the pancreas, because one of the biggest problems with pancreas carcinoma patients is that you have really early infiltration of the lymph system or lymphatic system. So this is mostly in the status if you have a diagnosis of a pancreas carcinoma or pancreatic carcinoma. It's very common that you are in a late stage of disease because you have a lymphatic infiltration, which leads then to these very fast progression of disease. And I also mentioned that if you have a look on organs, you should always keep in mind that there are also some collecting lymph nodes around, which are then responsible. They're acting like we call it as sentinel lymph nodes, because they're the first lymph nodes which are infiltrated and drained by their lymphatics there. Then we talked about the superior mesenteric artery. I also mentioned at that point that you have there some branches, you have some loops which are connecting, and you have a certain hierarchy. This is also visible here. You have A1 segment, A2 segment, A3 segment. So this is a segmental orientation, a bifurcation of the vessels which are building up a meshwork towards the small bowel, and so the blood supply there is very, very responsible on the fact that you have these supply over the whole network. So from the superior mesenteric artery you find, as I mentioned, the first is the inferior pancreatic adrenal artery. Then you have the supply of the jejunum and the ileum. So the jejunal arteries, the ileal arteries, and the ileocolic artery. The ileocolic artery, which is just here, is one of the last terminal branches of these systems. So it means if you have a thrombus or an embolus which could close and obliterate these blood vessels, it could easily happen that you have an ischemic gut, so you have to do an hemicolectomy for that. So the second one is that I mentioned for sure also the inferior mesenteric artery, which supplies the left colic artery and the sigmoid artery. Some words to the portal veins, or the veins itself. You see there are some anastomosis between the portal vein and the larger circulation. You see this is the connection between the iliac veins, and you have portocaval anastomosis from the gastric veins to the esophageal veins responsible for the varices, then the umbilical vein with the para-umbilical vein, which is here with their ligament, with the falciform ligament, and the third one is with the rectal plexus, so with the pelvic veins. You see, it could happen that you have also backflow, and then you develop some dilated blood vessels there. Yeah. Some words now to the peritoneal folds and the peritoneal spaces. So this is what I mentioned yesterday. In the course of the abdomen, you have the gut is sometimes within the abdominal cavity, sometimes without. And if you have these margins where you have a course of an intraperitoneal organ and an retroperitoneal organ, you have peritoneal folds, and this is frequently happens here. You see that in the duodenum. This is a fold which rise up here. This is a fold which rise up here. Often sure with the colon ascendens and the colon descendens, where you have also a crossing in peritoneal folds because the gut cross the peritoneum. Some words to the retroperitoneal space. So for the retroperitoneal space, you find all mostly the organs like the duodenum, the pancreas, both kidneys, the urethra, and from the urethra, all the big blood vessels like the inferior cava and also the aorta abdominalis. So it looks, if you do a cross section, you see this is with the white dashed line, this is the intraperitoneal space. This is the white dashed line is the peritoneum. And you see all in these package here in this system behind the white dashed line. This is the retroperitoneal space. So the retroperitoneal space is just here with the liver, with the kidney, encircled by fat tissue, the aorta, and the cava. So you see here the stomach, the left lobe, and the right lobe of the liver, and this is the spleen, the aorta, inferior vena cava, and the left kidney. And all the kidneys are encircled by a fascia. So this is the so-called kidney fascia, and around within the kidney fascia you find fat tissue. This is so-called adipose fat tissue. So do you have so far questions? Okay, let's continue. So let's talk about the kidney itself. So you have a perirenal fat capsule and a renal fascia. This is just the kidney is embedded there. So you have a perirenal fat capsule, and the fat capsule surrounds the kidney in the suprarenal gland. So if you're starving, it could happen that this fat capsule is resorbed, and then you have some kidney problems. Kidney failure can also arise from the fact that you lose fat tissue of the perirenal fat capsule. So, and this is how it works. So you have here the fat capsule itself, and then you have the renal fascia with the posterior layer and the ventral layer, which encircles then as a fibrous capsule the kidney. So some words on the kidney itself. So on the kidney, on the upper part of the kidney, you have the suprarenal gland with the superior suprarenal artery, the medial suprarenal artery, and the inferior suprarenal artery. As I mentioned yesterday, superior, so the superior suprarenal artery rise from the inferior phrenic artery, the the medial suprarenal artery comes from the aorta itself, and the inferior suprarenal artery comes from the renal artery. So encircled, you find here the adipose fat tissue, so the fat capsule, and then you have here at the hilum the different arteries and the urethra. So you have the right renal artery and the right renal artery and the right renal vein and the urethra. If you do now a cross section, you find here the renal papilla with the papilla from a foramina. This is a little bit, looks like a perforated area. And between the papillas, you find the columns. So these are called the renal columns. And the renal columns are just going down to the calyx of their kidney. At the end, you find the cortex. This is the renal cortex, which is, you have the renal cortex and the column and the papilla. And this is an area you call the medulla. So renal cortex and medulla, the pyramid system. So if you take a look on the renal pelvis itself, so variation of the renal pelvis, you see at the end you always have the urethra, but the division of these calyxes, so of the superior and the inferior calyxes is very different. You can have a large one, this is visible on C. You can have a very bifurcated calyx system, this is seen on A, or you can have just two ones. So there's a certain variation in there, and we call it linear pattern, dendritic pattern, and an amparallel pattern. Some words from the development of the kidney. This starts at day 24, 26 after gestation. You see, everything starts with the development of a pronephros. This is the first kidney that is developed, and the first kidney is developed by the cervical nephratomes. These are so-called nephratomes, and it's lying like sommets. So you have 45 to 50 of these nephratomes, and they get resolved, by the way. So after the development of the nephratomes, you first develop a so-called intermediate mesoderm. And from the mesoderm, connected to the mesoderm, you have the mesonephric duct. And from the mesonephric duct, you develop mesonephric nephratomes. Everything ends in the cloaca. The cloaca is the premature bladder. And the premature bladder goes over to the elangitis. So these are the three stages. So there's the pronephros, the mesonephros, and at the end, you have the metanephros, the final kidney. So at day 28, you have the mesonephros and the metanephric plastema. And the mesonephric plastema goes over with the mesonephric diverticulum. And with the mesonephric duct, so the mesonephric duct becomes the collecting tissue and the urethra, so the pelvis, and the rest shown here in this purple color becomes then the glomerular system. And already at day 36 to 50, we have the generation of bifurcations of the different collective tissue by the pelvis and the myocalves, and then you developed more and more branching points and do resorption, and then you have your final kidney. So everything starts, as I've shown here, with the metanephric tissue, the metanephric vesicle, the collecting duct, the handle loop, and the proximal convoluted part. After a while, you have if you have in the 6th week, you have an ascending of the kidney. So the kidney goes up by their elangitis. So it starts that you build up the nephrogenic plastema, and then you build up a rising of the kidney. You have questions? Questions?
Can you? I have a question.
You have questions?
I have a question.
Yeah.
Can you go back to the slide of the variation of the renal pelvis?
Yeah.
Which kind of the distribution is to the majority of people?
It's mostly the linear pattern. 80% is linear pattern.
Okay.
Okay, maybe we go further now. I just mentioned that you have to collecting duct, the convolute part, and you have this ascending of the kidney. And you see that you have an uprising of the kidney, both sides. But what they have to do is they have to cross the blood vessels there. And it could happen that if you have a misfolding, a misuprising of the kidneys, they miss their position and their location. So it could happen that the kidney is just attached to the lower renal artery, which you see here. Or it could happen that they have a fusion and then they are blocked by the superior mesenteric artery. And this is then called a horseshoe kidney. If you have a misuprising, a misascending of the kidney. You see that here. This is the called horseshoe kidney. The horseshoe kidney, the name comes from horses. The shoe of the horse is mostly made of metal, and it looks like that you have this U-like shape form of a horseshoe kidney. And it could happen that these kidneys have multiple urethras, and the urethra just going down to their bladder. You see that here, these are multiple urethra. This is the bladder. This is the bladder, and this is the kidney. You have 1, 2, 3, 4, 6 urethras in this case. So it's pretty much both sides. Now, some words, if you can have a cystic kidney, this is also really frequently. And I would say at least 5 of you have cysts in their kidney. This is nothing unusual, and it could happen that you have a complete destruction of the kidney by cysts. How is the course of the urethra? The course of the urethra starts with 3 parts. You have an abdominal part, you have a pelvic part, and an intramural part, which means the part or the course of the urethra in the bladder itself. So there's some intersections and possible narrowings of the urethra. So the first is passing the renal pelvis. The second is passes behind the testicular or the ovarian vessels. This is here. So we can have a compression of the urethra. So these are so-called intersections and possible narrowing points. So first is the passing of the renal pelvis. The second one is the passing of behind the testicular ovarian vessels. The next is the crossing of the common iliac vessels. And the last one, which is really, really frequently, is that you have the transverse of the bladder wall. So it's the so-called intramural part. The orifices are just next to the trigonum. So we call that a so-called trigonum. This is the so-called triomal, it's a triangle. And the special thing is with the entrance of the urethra is that it has a oblique course. So if you have a filling of the bladder, the orifice of the urethra is closed immediately. So this is something which Mother Nature made to preserve and backflow of the urine from the bladder to the urethra and the kidney itself. So from the orifice itself, this is sitting on the pelvic diaphragm, and this is a so-called transversal perineal muscle. So for the micturition, this is predominantly made by parasympathetic fibers. You see that here from the sacral mark, and they're coming from the pelvic splanchnic nerve. So this comes to the detrusor muscle, and the pelvic splanchnic nerve does the contraction of the vesical bladder. And for the sphincter itself, it's done by the pudendus. So the pudendus do the voluntary relaxation for the micturation, and then you have the internal sphincter at the cervix of the bladder, which do continuous constriction to preserve a loss of urine. So first you have the filling of the bladder through the perception via sympathetic and parasympathetic afferences. These are so-called stretch receptors. Then you have the detrusor vesical muscle, which contracts then voluntary. If you want to go to the toilet, you do a voluntary contraction of the detrusor. It's parasympathetic. Then you have an opening of the sphincter, which blocks the sympathetic afferences. So, and this is the only voluntary reflex. This is the external sphincter, which relax. And then you have by the pudendal nerve. And then you can do the micturation. So where's the micturation center? In the brain, it's in the pons. So it's a so-called pontine micturation center, which controls and coordinates the influence of the micturation itself. So how it works with the relaxation of the bladder. So the bladder is the bladder is now fixed by some muscles. This is so-called pubovesical muscle and the diaphragm, which builds the transversus perineum and the sphincter, the external sphincter of the urethra. You see, this is just located next to each other. So how is the vascularization of the bladder? You have the internal iliac arteries. From the iliac arteries, you have the obturator artery, the umbilical artery, and the superior. So you have the superior vesical arteries and the inferior vesical arteries. They are just down there. Yeah, how it looks in female, this is your view from the parietal cavity from cranially. You have the bladder, the uterus, and the rectum. And next to each other, you have the fallopian tube and the ovary and the ovarian fossa. And next to that, you have the cecum. And there are some pouches there. It's the so-called vesicouterine pouch. And this is the so-called rectouterine pouch. Next to the uterus itself, you find the broad ligaments of the uterus. And this is forming then the uterus itself. Some words to the uterus. So this is the adnex, the ovarian adnex. You have the ovary here with the medial and lateral surface. By the way, do you have some questions so far? I forgot to ask you. Do you have some questions? Hello?
I have one question. Um, uh, are, are there any difference between the size of the bladder between men and women?
Yeah, the volume is different. So it could happen that you have a volume up to 500 ml, and the volume of women is lesser, it's 300 or 350. So it's a smaller volume, but in terms of the function, it's the same. Okay.
Thank you.
Some words to the ovary and uterus. So you have between the ovary and the fallopian tube, the so-called meso-ovarium. This is a so-called meso. So the meso of the ovarium itself comes from the tube, from the fallopian tube and the ovary. So there you find the so-called ovary with the lateral surface, medial surface, and a vascular pole, and you have a uterine pole. And next to that, you find a broad ligament of the uterus. The ligament from to the uterine pole is the so-called proper ligament of the ovary, and the other one is a ovarian susparentary ligament, which is just down there. So then at the end you find the so-called infundibulum with the abdominal ostium of the fallopian tube, and they have a lot of fimbriae and abdominal ostium of the fallopian tube. Some words to the uterus. In the uterus, you find the endomedium, myometrium, so the muscle layer. This is the vascular layer. This is the muscle layer, and next to that, you have the perimetrium. This is the serosa, just covering the uterus itself. And at both sides, these are the so-called parametrial ligaments. So at the height of the uterus, you find a fundus, so-called fundus. This is the upper part. Then you have the whole body of the uterus. You have the cervix, and there are uterine cervix, the vaginal part, the vagina itself, the supravaginal part, the cervical canal, and the uterine cavity. This is the so-called isthmus. So this is just a part between the body of the uterus and the cervix. Normally, you have a folding, and the folding works that you have the bladder side and an intestinal side, and you have a certain angle there. It's and we call it an anti-version of the uterus. So it's the angle between the vagina and the cervix. Then you have also a folding there between the cervix and the uterus itself. It's a so-called antiflexion of the uterus. And this the positioning depends on the filling of the bladder. You see, this is depending here. If you have a huge filling of the bladder, the angle is also changing. The same is true if you're pregnant. In this case, also the angle is more or less changed. So full bladder, empty bladder, different angles there. Some words to the vascularization of the bladder and the uterus. So you have you have within the ligamentum latum a lot of blood vessels. These are the uterine blood vessels, which comes directly from the internal iliac artery. Here next to the system, you find the obturator nerve and the obturator artery, just located next to the uterus itself. So how are the perigeneal conditions in the female pelvis? So you have pelvic levels. First of all, the perigeneal level, the subperigeneal level, and the subfacial level. And the so-called, this is the spatium recto, so the recto-uterine space, the so-called ductless space. And this is the space between the bladder and the uterus itself. So we call that the rectopubical space. This is a field of fat tissue. This is the vesicovaginal space, and this is the rectovaginal space. This is just fat tissue. So this is the broad ligament of the uterus. So how about the male pelvic cavity? You see there are just one little excavation. So this is the excavation between the bladder and the rectum itself. So do you have questions? No questions. So is that too fast, too superficial for you? So do you have any questions so far?
I have a question.
So this is nothing new for you?
Can I ask something?
Yeah.
Yeah, is there, so we just give the perimetrium and the parametrium, are those muscles, or they're just the epitheliums that cover the outer side, the outer surface of the uterus?
And so the perineum, the perimetrium is just the serosa of the uterus. It's like a covering of mesothelial cells. And the parametrium, this is the more or less fat tissue and blood vessels, which contains then their uterine arteries.
Thank you.
I have a question about the volume of the bladder. It's on the slide of the full bladder and the empty bladder.
Yeah.
Yeah. When woman is pregnant and when she has and the baby is growing up, then the baby will push on the bladder. So it's so the bladder will decrease the volume. Is it?
Yeah. The volume is decreased during pregnancy, and the urge to go to the toilet is much more higher because you have a pressure of the baby on the bladder. So the frequency to go to the toilet is much more higher in this case.
Yeah. Yeah. Thank you.
More questions? Okay, well, let's continue then. So you see the height is also different of the pelvis, and it depends that you have these different levels between females and males of the spaces. So just between, you find very deep. This is the uterus. And this is the broad ligament. So this are the parametria. So these are the parametria. You see, these are more or less roads of blood vessels, which comes to the uterus there. And this is the level. This is the rectus. This is the uterus, and this is the bladder. You see, bladder, uterus, and this is here the rectus. What about the male? You see, this is the cross section of this. It's much more higher here. So we have accessory sex glands. The accessory sex glands are located just on the back of the bladder. You have the urethra on both sides. Then you have the vas deferens, so the ductus deferens. And around the vas deferens, you have the ampulla of the vas difference, and there you have the seminal vesicles. And the seminal vesicles are on both sides, and they have dimensions of mostly 2 to 1 or 2.5 centimeters, so they're just around that. And there you find at the end the ejectory ducts, where we have the secretion of the seminal vesicles. Beneath you find the prostate, and the prostate has 2 parts. So this is the ejectory ducts, where you have the secrete from the vesicle and from the testis. This is again the bladder trigon with the orifices, then here the prostate and the structures from the urethra. This is the prostatic capsule. Within the prostatic capsule, you have sometimes 40 to 50 tubular alveolar glands, which goes down and do a secretion for the prostate itself. For the prostate, we have different zones. So we have the outer zone, we have the inner zone, and we have a periurethral zone, which encircles the urethra itself. They can have a hypertrophy, which in elderly patients, which close then the cause of the urethra itself. How it looks with the urogenital rectal compartment, you see that here. This is the bladder. This is the structure itself. So it's everything is very close together here. Okay, do you have so far questions? So I have an 11 or so. This is for you. 4 o'clock next meeting. So do you have some questions?
So when a baby is developed in a woman's uterus, then the uterus just expand, right, in the abdominal cavity, right? So I was just wondering that inside the abdominal cavity has like space and gas in it, right? It's an empty cavity. So when, yeah.
So it's very expandable. It's very expandable in pregnant women. We can easily
wow. Okay.
Okay, so thank you very much, and then we schedule the next meeting. I would say I will do it by mail in the next days or next Saturday. So have a nice Sunday.
Thank you very much.
Bye-bye.
Thank you.